Both are cortical, sir.
Yes.
Okay. Okay.
53-year-old male with 6-month post-op closed bimalleolar fracture of the left leg with malleolar screws and anatomical plate of the lateral malleolus in situ. There was exposure
plate.
Yes, sir. There was exposure
exposed.
of the plate on 6 months follow-up. So we have removed the plate and we've done wound debridement and we've applied the post-operative slab for a period of 2 weeks.
What about the medial malleolus? Still is.
Medial malleolus is also almost fixed, sir. But since it's only 6 months, we retained the implant.
Okay. When do you remove the medial malleolar implants?
After
8 months to 1 year. 8 months to 1 year. If it's a good one, is there any implant in situ? Once there is a focus of infection,
yes, sir.
any implant in situ is the born infection.
Yes,
so you
sir.
should be very careful.
Yes, sir.
Right, sir. This also sometime later it may get infected. So you have to treat like a infected implant. Yeah.
14-year-old male with closed distal third both bone shaft fracture of left forearm. We have done closed reduction internal fixation with tens for radius and ulna.
Both nails, huh?
Yes, sir.
Why? What is your prerequisite for nail? Go back.
It can be treated as intra-articular one and the reduction was not achieved, sir. Closed reduction. And 14 years.
So that is the main important. 14-year child.
Yes, sir.
14-year child still is. So by all practical purposes, the both bone fractures should be treated as intra-articular fractures. So no displacement, no angulation, no rotation.
Yes,
have you given any forearm brace, no brace?
No, sir.
So all is well,
yes,
on table.
Yes,
so
sir.
even then you have to protect with the brace because you have used the tense nail. Tense nail cannot give you the rotational stability because it is a both bone fracture. For some time, minimum for 3 to 4 weeks, you have to give the brace till there is some evidence of good callus formation union. Yes, sir. But you have to protect the both bones because it's not a single bone. Yes. Yes.
7 years female, 7 years female with 7 months old post-op follow-up case of closed proximal third middle third shaft fracture of left femur with implant in situ, sir. We have done implant removal.
How many months old post-op?
7 months.
7 months. So there is solid union. Okay. The child is total weight bearing or partial weight bearing? Partial. Yeah. Sitting, patient is sitting, standing, walking, climbing, getting down. All is well. Yes, sir. Next.
58 years old male with intertrochanter fracture of left femur, sir. Boyd and Griffith type 2, sir.
Yes.
We have done close reduction internal fixation with short PFN, sir.
Okay. So what about the lateral malleus? It falls back into the position or there is something displacement?
Lateral malleus.
So what do you call this reduction? Positive reduction, negative reduction,
neutral,
or?
sir. Neutral.
Neutral. What do you mean by neutral? What do you mean by positive? What do you mean by negative? Srikanth.
Both medial cortex are same line, sir.
So the medial cortex is continuous, proximal and distal continuous is neutral. If the medialization of the distal fragment is negative, medialization of the distal fragment is negative, lateralization of the distal fragment is positive. So neutral, positive can be acceptable. Negative is not acceptable. Okay, right. Next, go ahead.
68-year-old female with intertrochanteric fracture of the right femur, sir. Boyd and Griffin type 2. We've done closed reduction internal fixation with proximal femoral nail.
Here also, how is the reduction? Little
slightly positive. Sir.
Yeah, little lateralized. It is not like. Okay, right. Good, accepted. Next.
50-year-old male with closed segmental fracture of left radius and middle third shaft fracture of left ulna, sir. You have done open reduction internal fixation.
Is a open injury or closed injury?
Closed type, sir.
Closed fracture.
High velocity. అంటే ఓపెన్ లేదని పెట్టలేదు సార్ అట్లా. No sir, close sir. No sir.
It is not a mangled. It is not a mangled limb.
Open.
Is it a crush injury? No crush injury?
Crush injury, sir.
It's an open comminuted compound.
Normal only, sir. Soft tissue.
Is there any compartmental syndrome? Is there any positive finds? Is impending ischemia?
Sir, when we closed, it was a little tight, sir. But we elevated the limb and asked him to do RO.
So
finger movements.
when the patient got admitted, when do you operate it?
Second, I think, sir,
Second day
after the injury.
after the injury. Second day only you are operated.
Yes. We have done-
So go back. So go back. So for any orthopedic, ఎవరికైనా సరే 6 points are very important. Clinical, pre-op, intra-op, post-op, follow-up, and clinical videos. This is a mandatory because these are all the challenging cases. It can be presented like a poster. Yes, sir. Go ahead.
Normal, sir. We have done open reduction internal fixation with nailing for left radius and plating for left ulna, sir. Ulna, sir. Radius. Segmental. Long plates were not available, sir, that long.
Go back.
Reduction is
Is there any butterfly fragment? Butterfly fragment is there?
small piece is there, sir. Yes. Yes, sir. Actually, X-ray is looking like this, sir. But intraoperatively, what we found out was ulna was 4 pieces were total 4 pieces were there, sir.
Allah.
Yes, sir.
Yes, sir. So what are the go back?
Below the radial styloids. 2 centimeters below the radial styloids.
Is it dorsal entry or volar entry, Gardner's tubercle, styloid tubercle? ఎక్కడి నుంచి entry point?
Two centimeters below the radial styloid.
Below the radial styloid.
Lateral side. Dorsal.
So what is the tubercle?
Lister's tubercle.
Huh?
Lister's tubercle.
Lister గట్టి మింగితే ఎట్లా గట్టి లిస్టర్ tubercle. Yes.
Irritation can occur, sir.
తర్వాత one more point. Oh, go back, sir. So always in segmental fractures, there is one fragment unites with the parent bone, one fragment won't unite. So you are using the tense nail. What is the mm? 2.5 mm, 3 mm?
I think 3 mm, sir.
Huh? 3 mm. So the problem with the segmental fracture is one segment will have the micro motion, other segment will have the macro motion. So it is a body's mechanism when to generate osteogenic potential cells, when to generate osteoclastic cell. If the difference at the fracture side is more than 3 mm, so they generate delayed union, osteoclastic activity. It's a body space. It is not even a control. So one fragment unite, other fragment on other unit. So where there is a micro motion, there is osteogenic potential. Where there is a macro motion, there is a osteoclastic activity. So this is a body space. It is not in our control. So more than 3 mm, whether diaphyseal fractures of long bones, always you should be take care. So that's why you should be very, very careful. So there is no bone grafting, nothing.
No, sir.
Yeah, all is well on table.
Yes, sir.
Yes, sir, go ahead.
Radius, sir. Absolute stability.
So you have to protect. You have to protect.
Bigger, sir.
So you have to protect with the forearm brace. Forearm brace, you see, you have to follow minimum for 6 weeks because it is a segmental fracture. Because you don't have control over the middle fragment.
Yes,
That too is a titanium elastic nail. It's a smooth nail.
yes, sir.
It is not a rectangular nail. It cannot prevent the rotational deformation forces. So by all practical purposes, the both bones forearm should be treated like intra-articular fracture and should be treated like intra-articular fracture. No angulation, no displacement, no rotation activity. Yes, sir, please go ahead.
38-year-old male with 1 month old closed middle third, distal third shaft fracture of right tibia, sir. We have done close reduction internal fixation with interlocking nail for right tibia, sir. At the 1 month old, sir. At fracture site there were mobility also. No, sir. History of native treatment was there, sir. Fracture ends are sclerotic.
With bone grafted,
We did
without
not
bone graft.
open the fracture site, sir. No, sir, closed. Closed. Yes, sir. At the distal, sir.
Is it a punctured wound or abrasion? Abrasion.
Abrasion.
It's not a punctured wound. So it is a bone grafted, not bone grafted. Not bone grafted. So all is well. For operative bleeding, everything is good. Right. So, but the fibula is intact. In intact fibula, what is the
Sir,
problem?
Fracture of head.
No. Head is there, yes.
Head of him.
ఉన్నా కూడా ఫిబులార్ హెడ్ ఇంకా జాగ్రత్తగా ఉండాలి. వై
Biceps femoris.
దేర్ వై ఒకటి బైసిస్ ఫిమరస్ ఇంకా there may be peroneal palsy later date. You should be very careful because so all cortices are good in contact. Anterior cortex, medial cortex, posterior cortex, all are good. Which cortex is the weight bearing cortex of the tibia? Anterior cortex or posterior cortex?
Anterior.
Anterior. Yes. Venkateswara, which cortex of tibia is called as the weight bearing cortex? Anterior. Srikanth, Abhiram, posterior cortex is the weight bearing cortex. నీ స్వామి రంగా చదివేస్తే ఉన్నది వెళ్ళిపోయిందంటే ఇన్ని రోజులు అయిపోయింది ఎగ్జామ్ గోయింగ్ బ్యాచ్. విచ్ కార్టెక్స్ ఇస్ వెయిట్ బేరింగ్ అంటే పోస్టీరియర్ కార్టెక్స్, యాంటీరియర్ కార్టెక్స్ అంట. వాట్ టైప్ ఆఫ్ బోన్ ఇస్ టిబియా? ట్రయాంగులర్ బోన్. ఎట్లా నువ్వు అది go back. See, what about the posterior cortex? Good or bad? Show me the posterior cortex. Show me your pointer. Everyone should carry their pointer. మరి కొనాలి సార్, కొనాలి, పాయింటర్ పెట్టుకోవాలి. There is a gap at the fracture site, no gap at the fracture site. Medially there is a gap at the fracture site, no gap at the fracture site.
Sir, somewhat, sir. Not much gap. Not much gap, sir.
అదే చెప్పింది, less than 2 mm, more than 2 mm, అదే చెప్పింది. So they may go into delayed union or non-union later date.
Sir, fibula maybe. herniation we can do, sir, and fibrectomy we can.
You want to put a bone graft, no bone graft, or you want to use BM,
Fibrectomy and we can.
fibulectomy.
Oh,
But at the level of fracture side we can.
Osteotomy.
Yes, sir. Osteotomy.
And bone morphogenic proteins. Bone morphogenic proteins also in early case. Because go back. So it is almost at the level of distal third and middle third junction, where that is the narrowest part of the tibia, where the vascular supply is precarious, less ఉంటుంది. That is also very important. So very, very important. Yes, sir. It's a weight bearing limb. Weight bearing limbs demands mobility and stability. Yes, Dr. Sir. Upper limb demands mobility and function. Yes.
60-year-old male with closed middle third shaft fracture of right humerus with no DNVD. We have done ORF with plating for right humerus, sir.
3-3. AO acceptable, not acceptable.
Acceptable, sir.
So usually AO say in upper limbs
3-3.
proximal 4, distal 3, lower limbs distal 4, proximal 3. That is AO principle. Why? Because the abductor mechanism, the deltoid tuberosity is abduct. So abduction, external rotation, abduction, external movements are very high. So there is some amount of pull out strength.
The transverse fracture, sir. Sir? Not involved, sir. Not involved, sir. Normally middle third, distal third shaft fracture, there will get entrapment of radial nerve, that is Holstein-Lewis fracture. We may get, sir. Middle third, distal third. Yes, sir. Yeah. Yes, sir. Straight, sir. Yes, sir. No.
Years female with closed middle third shaft fracture of right clavicle, sir. Almond type 1, group 1, sir. We have done open reduction with plating for right clavicle, sir, with the interfragment. His combination is there. 32, sir. Yes. Yes, sir. Female. Combination is there, sir.
No lung injury, no distal neurovascular,
No,
everything
sir.
is
No
normal.
development.
No tenting, nothing is there.
No
Okay.
tenting, sir.
So you are using the Allman classification. Now the better classification is AO classification. That you have to standard. The Allman is outdated now. AO classification you start.
Okay.
What is advantage of AO classification?
Simple.
Even it talks about segmental
Segmental.
fractures of the clavicle. Yes, go ahead.
A 42-year-old male with closed middle third shaft fracture of the right femur, sir. Winquist Hansen type 0. We've done closed reduction internal fixation with interlocking nail for the right femur. Yes, sir. Closed.
What is the classification?
Winquist Hansen.
Winkel's Hansen classification for interlocking nailing. Danikadi. So diaphyseal classification, AO diaphyseal classification maybe it can be simple fracture, it can be wedge fracture, or it can be comminuted fracture.
Yes, sir.
AO ఈ సాయంత్రం అన్నిటి ఒకటే కల్పిస్తుంది. వింకిస్ట్ క్లాసిఫికేషన్ ఫర్ ILNL.
Yes, sir. Mid shaft. Yes, sir. Nailing, sir. Nailing. Sir, but this can allow early weight bearing, early mobilization.
It is a weight sharing device. You are not evacuating the fracture hematoma.
Yes, sir.
So you are caring for the soft tissue.
Yes, sir.
So it is something like early mobilization, better
Yes.
early mobilization. Yes, sir.
47-year-old female with 6 weeks old posterolateral dislocation of right elbow, sir. We have done open reduction and stabilization with K-wire, sir.
Use one K-wire is enough, or better to have two K-wires?
Intraoperatively, the radiocaptor joint was very stable, sir. That is why we did not put another K-wire, sir. Posterolateral dislocation of the elbow joint, sir. Posterolateral only common, sir. Yes, sir. Only little flexion was coming, sir. Until 30 degrees was it was. Only 30 degrees was coming, sir. Yes. No, sir. The ROM was not there, sir. That is the reason she came, sir. Little pain was also there, sir. Only dislocation is there, sir. No fractures. Nice, sir. Maintained. No dislocation. No fractures, sir. MRI we have done, sir. Nothing was there, sir. Fine, sir. MCL and LCL are fine, sir. We have to do reconstruction, sir. We have more than 3 weeks. We call it neglected, sir. Yes. Close reduction, sir. Close reduction can be tried until 6 weeks. It is written in Rockwood and Green, sir. We may get reduction or not. If we don't, sir, we tried in this, sir, but we did not get the reduction, so we had to go for open reduction, sir. Yes, sir, we got, sir. At least 90 degrees we have got.
So it's a dominant elbow. Hand to mouth, everything is good.
That is the main problem why she came to us, sir. She was not able to eat, sir.
Then what you have done? Now, after reduction and everything, she can able to.
We have immobilized her in a slab, sir, for approximately 3 to 4 weeks. After that, we will start mobilizing her.
3 to 4 weeks, already 6 weeks. So it go into stiff elbow. You have to go for intermittent physio immediately. Intermittent physio. Only active physio is advised. No passive physio.
Sir, slab system, sir, she is trying to flex and extend her elbow. That is why the pin got bent, sir. Can't do nothing, sir. No, sir. Yes, sir.
Just like ROM and knee brace, ROM, range of motion knee brace, we have got ROM elbow brace also.
Not available in our medical shops, sir.
Not available. Hyderabad is very next to you. People are going to London, going to Paris and America. Night going, they are having breakfast. Next day they are coming to India. So much of technology is there.
60-year-old female with 1-year-old right tendo Achilles tear, sir. 1 year, sir. She is having difficulty in walking, it seems, sir. No, sir. Pain was there, sir, but they neglected it, sir. Pain, sir. Yes. Pain and difficulty in walking, sir. Yes, sir. Yes, sir. Close, sir. Close. Cardiac, sir. Yes. Tendon is not exposed, sir. It's closed, sir. Sir, left, sir. Adi. Sir, right, sir. Adi.
Yeah. Pointer use and sir. Use the yourself. మీకోసం pointer. Run. తీసుకో.
We have done
Pointer is meant for you,
tendoglyphs.
not for me. Or use the pointers. Use the pointer, sir. Venkateswara, please use the pointer.
We have done tendoglyphs reconstruction using FHL graft.
Pointer. How much gap is there? Flexion extension?
6 centimeters.
6 centimeters.
Yes, sir.
So dorsiflexion and plantar flexion.
Yes.
6 centimeters.
Yes.
Which is more? Plantar flexion is more, dorsiflexion is more?
Dorsiflexion will be more, sir.
More.
Yes.
So when do you advise augmentation maneuvers? Augmented with FHL or peroneus brevis or with the plantaris
The gap is more than 3
or
centimeters.
Vulpius, Straits, was there? So many procedures are there. Acute tendoculi is different from chronic. Is an acute or chronic?
Chronic, sir.
Chronic. So you are augmented with FHL.
Yes.
Video
Video play తెలవు sir.
play అది అడగాలి, అది చెప్పాలి. You a lot of time. అది చెప్పాలి, videos are not playing అని చెప్పాలి. Yes sir.
Sir. Sir. Below, sir. Yes, sir. We have touched. Yes, sir.
Zoom చేయండి సార్.
Yes, sir. Yes. This is the FHL, sir. This is the tendoculi, sir. No, sir. Muscle belly we have. Tendinous part only we have taken, sir. Yes, sir. Using crack or suture. Yes, sir. Yes. 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 Yes.
have you used endopotin or not? Used or not used?
Used.
And then why you used అంటే అదే చెప్పాలి కదా, why you use endopotin? Reason. See, you have to show all the images. Intraoperative images చూపించాలి. How you have taken the graph. Videos are not playing.
Year-old female with closed lateral plateau of tibia, right tibia fracture, sir. It was doubtful on the X-ray, so when the CT scan was done, we found a displaced fracture of the lateral condyle.
Is a split fracture or a split displaced?
Split.
Split displaced or only split?
Split and displaced.
Split and displaced. Type 2.
Yes, sir.
Surgical radiological classification.
We've done open reduction internal fixation with plating for the right tibia, sir.
What is the name of the plate?
Proximal tibia anatomical LCP.
Periarticular locking compression plate.
Yes, sir.
Yes.
40 years old.
Periarticular contoured locking compression plate.
We have done implant
EO
removal.
plates. When do you remove the implant? Go back. Go back, go back.
After 1.5 years.
1.5 year. For clavicle, you won't have 1.5 year. When the clavicle usually needs 6 months to 9 months, less than 1 year.
Good morning, sir. These are the cases done in Unit 3. 14-year-old boy with 7 months old post-op case of closed middle third both bone fracture of left forearm with implant in situ. We have done TENS removal. Yes. Before and after, sir said to kick off.
From where do you remove the radius tens? From where do you remove the ulnar tens? Firdos.
Radial from the distal.
Use the pointer. Use the pointer. You got the pointer, no? From where you have removed the tens nail for where pointer ma?
Radius.
Green pointer. దాన్ని యూజ్ చేయని అది ఇచ్చింది మీకు రావాలి, ట్రైనింగ్ రావాలి, పోడియం ప్రెజెంటేషన్. ఎస్ సార్, దట్ ఈస్ ఫర్ రేడియస్. అల్లా అల్లా ఇక్కడ లేటర్లో చూపించు. సో నో ప్రాబ్లం. సో వెన్ యూ ఆర్ రిమూవ్ ద నెయిల్స్? 7 months. What is age of the patient? 72 years female. 72 years female. अरे नहीं सायरंगा. Go back. पहला लगाओ.
14 years.
वो लगाओ, अच्छा बोलना वो बोल दिए, ये लगा दिए.
72-year female with 3 weeks old, closed proximal third both bone fracture of right leg and 7 months old post-op follow-up case of intertrochanteric fracture of right femur with implant breakage. We have done MIPO for right tibia and implant removal for the femur, sir. No, sir. After 3 months.
So what is the problem there? Is a Z effect, reverse Z effect? All effects are there.
Reverse head effect.
Reverse. What is reverse Z effect?
Distal fragment goes medial. Distal screw goes medial.
Yes, for those, can you enlighten better way? What is Z effect? What is reverse Z effect?
This is reverse head, sir.
Lateralization of the distal screw is called as reverse Z effect. Z effect.
No, this is reverse.
or medialization. That is medialization. So reverse Z effect में क्या होता? Proximal screw will be lateralized. ఇది లోపల పోయింది, బయట పోయింది. It is almost like reverse Z effect.
Okay.
So all communicated.
Sir? Yes, sir. Normal. 32-year male with a closed middle third shaft fracture of right clavicle. We have done ORF with plating for right clavicle and interfragmentary screw. No sir. No sir. No sir. No sir. No sir. No sir. Super inferior sir. Yes sir. No, no, yes sir. Yes sir. No sir. No sir. 22-year-old male with a closed bimalar fracture of right ankle. It's a Log-Hansen type supination external rotation. External rotation. Abduction sir. Sir. Yes sir. Supination external rotation. Mean adduction. Yes sir. Adduction. Adduction injury sir. Adduction injury sir.
So medial malleolus will have a transverse fracture in abduction injuries. Mari, in adduction injuries, it is an oblique
Middle
fracture.
malleus is transverse sir. Yes sir. Yes sir. We have done plating for right fibula and malleolar screw for medial malleolus. Yes sir. So mortis is not. This is mortis view sir, but AP we will not take a proper. Yes sir.
Good morning, sir. These are the cases done in Unit 2. A 42-year-old male with malunited middle third shaft fracture of right tibia with no DNVD, sir. So there is no mobility at the fracture site. Deformity is present. Patient wanted. Yes. Yes, a patient is walking, sir. Actually, yes, sir, with no pain, sir, but deformity is present, sir. 10 years old ILN was done. Deformity. Yes, sir. If there is no pain and there is no mobility at the fracture site. Yes. Mean squeeze test.
Yes, next, madam. It is not fibulectomy, fibular osteotomy at the fracture site.
We have done ORIF with ILN and bone grafting with fibulectomies.
Fibulectomy kaadu,
Fibula.
osteotomy of the fibula at the fracture site. So length is maintained, all is well. Yes, madam, go ahead.
31-year-old male with 6 weeks old distal and radius fracture of left wrist, sir. volar button. 6 weeks. 6 weeks. Yes. Patient is having restriction of movements and deformities. No, sir. No, sir. We had
You
a
have to
nod.
always examine the patient in a anatomical position. Go back. ఎక్కడ anatomic position? ఇది anatomic position. Anatomic position చూపించాలి. That is very, very important. Last time also I told you, anatomical position examination is very, very important to get the clear analysis of deformity and corrections.
United, sir. Yes, callus was removed intraoperative. Clinically, yes. Deformity, yes, sir. Deformity and movements are restricted. No, sir. No pain, sir. No, sir. Yes. Slab is applied. Rajshekhar. Yes. Yes. No, sir. Slab is applied. Yes. Mm. Sir, no, sir. Dorsal slab is applied. Yes. Dorsiflex will dorsiflex the wrist and will apply volar slab.
See, there are two buttons, volar button, dorsal. Volar button should be immobilized in volar position. Dorsal button, dorsal position. Because there is radiocarpus ligament, radiocarpal ligament is there. That should be maintained. That is a basic fundamental. Which button is more unstable? Volar button, dorsal button.
Volar button.
See, that is volar button.
No, sir. Under CM, they have checked. No, sir. Dressing. He is immediate post.
It is a variable locking compression plate. That is good. But anatomy you have to restore. Yes.
75-year-old female with fracture neck of left femur. Yes. Subcapital. Subcapital. arthroplasty with AMP for left. There was a GT sir, yes. With AMP. No, no, sir. There was a fracture intraoperatively for during femoral neck preparation. Yes. But, during femoral canal preparation, there was an avulsion of the greater trochanter has occurred. So we have to, because pyriform is forced. Yes.
You have to make a trough in the GT. Through the trough in the GT, you have to make it. The tip should be pointed
Yes.
towards the medial cortex.
Late rotation. No, no, sir. Uncemented. Mm. 75 years. No. Yes. So we have applied an SS wire for the. Yes, sir. Yes, sir. Yes, sir. It is. Yes. Yes, sir. These.
Have used the same bone. You have used the bone. So whatever bone is there, head whatever removed, you should pack it in the medullary canal. Autogenous graft.
Good morning, sir. Journal for today. Let us agree to disagree on operative versus non-operative treatment for proximal humerus fractures. Who is agreeing with this? Are you agreeing, sir? Yes, sir. Yes. This is a multi-center international prospective cohort study taken from Journal of Bone and Joint Surgery, which is published in 2025. Mm. They, in this journal, they have made two teams, sir. One. Yes, sir. They have given that. In Introduction. Proximal humerus fractures are among the most common fractures in adult and the elderly. Despite numerous randomized controlled trials and meta-analysis, there remains no clear consensus regarding the superiority of operative versus non-operative treatment, especially for displaced fractures. So the aim of the study is to compare operative versus non-operative treatment of displaced proximal humerus fractures in patients with clinical equipoise using a multi-center international prospective cohort design focusing on functional and quality of life outcome at 1 year. Materials and methods. This is a international multi-center prospective cohort study designed as natural experiment based on geographic variation in treatment preference. Study centers are 3 hospitals in Netherlands and 2 hospitals in Switzerland. Sample size is 266, out of which 115 non-operative patients in Dutch hospitals and 111 operative patients in Swiss hospitals. Study duration, patient inclusion is done from July 2020 to March 2022 and follow-up completed by March 2023. Yes, sir. Inclusion criteria is age more than or equal to 18 years, acute displaced proximal humerus fractures, and clinical equipoise. Disagreement among expert panel regarding optimal treatment. Exclusion criteria: delayed presentation more than 3 weeks, open fractures, pathological fractures, fracture dislocations, neurological and ipsilateral upper limb fractures. They have included, this is how they have distributed the fracture distribution. AO11A 2-part fracture 29% and AO11B 30%. AO11C 4-part fracture, it is 41%. 4-part. Treatment strategy: non-operative sling immobilization with 3 to 6 weeks and analgesia, supervised physiotherapy. Operative treatment, surgical options include minimally invasive plate, osteosynthesis, fillers, or open reduction internal fixation, intramedullary nailing, reverse shoulder arthroplasty, and choice of surgery based on local protocol and surgeon expertise. Results are: primary outcome, quick dash score, there is no significant difference at 1 year. For secondary outcomes, so shoulder, subjective shoulder value, EQ 5D index and health score, numeric rating scale, and return to work and sport. Operative treatment gives better pain relief and shoulder perception, but no functional advantage at 6 weeks. There is no long-term functional superiority of surgery. Complications are more in operative for secondary revision and secondary surgeries. Implant failure is more in operative, and there is no loss of reduction, and now pulses are more in operative, which is 2.7 and 1.8. Avascular necrosis is 0.9 in non-operative, and symptomatic malunion and non-union are symptomatic malunion is more in non-operative. Symptomatic non-union is same in both. Yes, sir, they have given. They didn't give anything. Because in type 4, they have went for arthroplasty, sir. Actually, operate. Yes. They have. Same rate. There was no significant difference in long-term functional outcome between operative and non. Whereas non-operative treatment showed biological complications such as malunion, avian, and persistent pain. The findings support patient-tailored shared decision-making, reversing surgery for selected patients. Reserving surgery for selected patients like young patients, active, or those requiring early pain relief, rather than routine operative fixation. Criticism: this is not a randomized control trial. Different operative methods grouped together, which limits procedure-specific conclusions, and short follow-up of 1 year. where long-term complications are not. Yes. Mostly I have seen operative only, sir. That's why I have chosen general, because these days whatever the cases are coming, we are choosing for operative only. Uh, if it is undisplaced only, if it is minimally displaced. uh, Implant failure and AVN, sir. No, sir. Will immobilize for 6 weeks, sir. The sling. No, sir, depending on the surgeon. Operative, yes. Yes. Many. Many. Yes, sir. Yes, sir. Oh. So depending on surgeons. Sir. Proximal humerus. Forty-five, 45 degrees. Yes, sir. Yes, sir. Operative. Netherlands. Yes. But these days for old people also people are operating. That's why complications are there. Yes, sir. Titles.